Hello, everyone, and thank you for joining us. I'm Dr. Jonathan Sakia, and today I'll be moderating this webinar entitled Management of Atrial Fibrillation with Acute Coronary Syndrome and/or Undergoing Percutaneous Coronary Intervention. We'll begin with a presentation from Dr. Amit Vora, who's an interventional cardiologist at UPMC Pinnacle in Harrisburg, Pennsylvania, and he's an adjunct assistant professor of medicine at Duke University in Durham, North Carolina. Dr. Vora will be discussing patients with both atrial fibrillation and acute coronary syndrome and assessing whether they should undergo percutaneous coronary intervention. Following this presentation, we'll conduct a live Q&A session where I'll be posing your questions to Dr. Vora. So please do take note of the question and answer, the Q&A box at the bottom of your screen, where you can input your questions throughout the presentation. And with that, I'll hand over to Dr. Vora.
All right, well, thank you very much, Jonathan, for that kind introduction. As you mentioned, I'm an interventional cardiologist at the University of Pittsburgh Medical Center, Pinnacle Heart and Vascular Institute, as well as an adjunct assistant professor of medicine at Duke University. And I wanted to spend a little bit of time discussing the management of patients with atrial fibrillation, with acute coronary syndrome and/or undergoing PCI, some insights that we've discovered from the AUGUSTUS study. And so here are my disclosures. And also, before we get started, I really would like to acknowledge Renato Lopez, who was the principal investigator for the study. Obviously, there are a number of folks that worked very hard and very diligently on the study, but Renato did a fantastic job and really was very helpful in providing these slides and providing the primary data as well. And so when we talk about atrial fibrillation and PCI, I think it's important to take one step back and talk a little bit about the epidemiology. So if you consider that there are about 1 billion people in the European Union and the United States, approximately 15 to 20 million of these folks will have atrial fibrillation. And of these, about 80% or 16 million will be indicated to take oral anticoagulation to reduce their risk of stroke. Now, the challenge is that approximately 5 million of these patients also will have concomitant coronary disease, and approximately 1 to 2 million will need revascularization, either via percutaneous coronary intervention and stent placement or coronary artery bypass grafting. And so when we talk about atrial fibrillation and coronary disease, there are very much overlapping patient populations as well as overlapping indications for antithrombotic therapy. And there are really a number of factors that need to come into consideration. When we talk about patients that have coronary disease, and again, this includes either acute coronary syndrome or recent PCI stent and CABG, we have to think about their antiplatelet therapy, which generally has included dual antiplatelet therapy with aspirin and or clopidogrel or one of the new P2Y12 inhibitors, such as prasugrel or ticagrelor. And then there are also emerging data for the use of the non-vitamin K based oral anticoagulants, such as rivaroxaban. When we're thinking about these therapies, we have to think about the doses. If they receive a stent, what kind of stent do they receive, a bare metal or drug-eluting stent, the duration of therapy, their bleeding risk, specific subgroups, their genetic considerations, specifically with clopidogrel, and then also cost. For patients that have atrial fibrillation, we want to do everything that we can to reduce their risk of stroke. In general, folks have focused on oral anticoagulation, so either with VK or vitamin K antagonists such as warfarin or one of the NOACs. There may also be some role for antiplatelet therapy. And when we think about these therapies, again, we have to think about a number of factors, including their overall risk of stroke, which generally is characterized by the CHADS-VASc score, their bleeding risk, which generally has been characterized by the HAS-BLED score or Atria score #1 or any number of other risk stratification measures. We have to know their renal function because there are dose considerations. Again, certain subgroups, heart failure, diabetes, renal dysfunction. For warfarin, we have to consider monitoring, whether that be with INR monitoring either at the point of care or in a clinic. In the setting of catastrophic bleeding, we have to think about how we're going to reverse these agents, if there is even an option or some sort of therapy that's available to reverse. And then also, importantly, we have to consider cost. And so each of these are challenging in and of themselves, but together it becomes next level in terms of the difficulty. And so, as I mentioned before, in general, for folks with coronary disease, they tend to be on dual antiplatelet therapy. And this is really to reduce the risk of stent thrombosis if a stent was placed, or recurrent ischemic events such as recurrent myocardial infarction. For folks with atrial fibrillation, they tend to be on oral anticoagulation to reduce their risk of stroke. The challenge with this scenario, though, is that for folks that have both, and we place them on both dual antiplatelet therapy as well as oral anticoagulant therapy, or triple therapy or triple antithrombotic therapy, that can significantly increase the risk for major bleeding. And the real difficulty in these patients is that it is very difficult to simultaneously prevent all three. Prevent MI or recurrent MI, prevent stroke, and then also to prevent major bleeding. What compounds this is that there are a bewildering number of strategies in the ACS patient with atrial fibrillation. And so when you look at just a couple of factors, such as the aspirin dose, the aspirin duration, which P2Y12 inhibitor you're using, the P2Y12 inhibitor duration, whether you're using an oral anticoagulant, and whether you're pursuing either sort of a low dose or a high dose strategy, over the course of 1 year, there are almost 3 million different permutations in terms of the different types of strategies that can potentially be employed. And in this particular field, and in cardiology in general, the overall challenge has been that a number of our guidelines really don't have a significant evidence base behind them. And so this was a study that was done by one of my colleagues, Alex Faneroff, and when he looked at the guidelines, both by the ACC-AHA as well as by the European Society of Cardiology, less than 15% of all of the guidelines really had evidence with a level of evidence classified as A, which is the highest level multiple randomized trials. And so not only are there a bewildering number of permutations, but historically there has not been a whole lot of evidence in this particular field guiding physicians as to the best strategy. Now, the good news is that over the last 5 years, there has been tremendous work in terms of devising the optimal antithrombotic strategy for these patients. The first study that was presented and published was the Pioneer AFib PCI study that was published in 2016. And this study compared 2 doses of rivaroxaban versus the traditional vitamin K antagonist-based strategy. And the Pioneer study demonstrated the safety of both of the rivaroxaban-based strategies when compared with vitamin K antagonist. The second study, Redual PCI, looked at 2 doses of dabigatran, 110 milligrams twice daily and 150 milligrams twice daily, compared with a traditional VKA-based strategy, and again demonstrated superior safety with the dabigatran-based arms compared with the traditional vitamin K antagonist-based arm. We'll spend a little bit of time talking about AUGUSTUS. And then the last study was Entrust AFib PCI, which looked at edoxaban and again demonstrated the overall safety with an edoxaban-based strategy compared with a traditional vitamin K antagonist-based strategy. Now, it is important to note that none of these trials were powered for efficacy. And the main reason for that is really one more of logistics. If you look at the original AFib trials, they required between 10 and 20,000 patients to demonstrate a stroke reduction in these patients. And so to design a study that would be powered both for safety and for efficacy in this patient population would require another study that was in the tens of thousands of patients, which unfortunately is just challenging from a feasibility perspective. So the AUGUSTUS study had a unique study design. And what we did was we randomized 4,600 patients in a 2x2 factorial design. And so what that means is that patients were initially randomized to apixaban at the dose that had previously been approved for stroke reduction. So 5 milligrams twice daily for most patients and 2.5 milligrams twice daily in selected patients versus vitamin K antagonists with a goal INR of 2 to 3. Then there was a second independent randomization for aspirin versus aspirin placebo. And the key with this particular trial design is that it allows us to identify the independent importance of both the novel oral anticoagulant versus warfarin, as well as the independent contribution of aspirin versus placebo. And that is one thing that is particularly unique about AUGUSTUS and something that the other studies were not able to as clearly disentangle. The primary outcome for AUGUSTUS was major bleeding as defined by the International Society for Thrombosis and Hemostasis, as well as clinically relevant non-major bleeding, with secondary outcomes being death or hospitalization and death or ischemic events. The inclusion criteria for the study were particularly broad and included patients with really any type of AFib that for whom physicians felt that oral anticoagulation was necessary and appropriate. And then patients needed to have either an acute coronary syndrome and or undergo PCI with a planned P2Y inhibitor duration of at least 6 months. Exclusions were primarily for contraindication to dual antiplatelet therapy or inability to tolerate any of the particular medicines that were studied, as well as other conditions that require oral anticoagulation, such as prosthetic valves, DVT, et cetera, as well as severe renal insufficiency or a history of intracranial hemorrhage. And so this study really demonstrates the primary findings of the AUGUSTUS study. And so for the primary endpoint, ISTH major clinically relevant non-major bleeding in the comparison between apixaban and vitamin K antagonist, there was a 30% reduction with major bleeding with apixaban compared with vitamin K antagonist. This translates to an absolute risk reduction of 4.2% and a number needed to treat of only 24. This finding was consistent across key subgroups, primarily patients that had medically managed ACS, patients that had ACS and underwent PCI, as well as patients that underwent elective PCI, with an interaction p-value of 0.052. When we look at the aspirin versus placebo comparison, there was an almost twofold increase with aspirin compared with placebo, which translates to an absolute risk increase of 7.1% or a number needed to harm of 14. And this again was consistent across the key subgroups of medically managed ACS, ACS requiring PCI, and elective PCI. When we look at all four groups together, the highest risk of bleeding was in patients that had VKA and aspirin, which is the traditional triple therapy group. And the lowest risk of bleeding was in the apixaban and aspirin placebo group, with an absolute risk reduction of 11.4%, which translates to a number needed to treat of 9 patients. When we look at ischemic outcomes, so death or hospitalization, there was a 17% risk reduction with apixaban which translates into an absolute risk reduction of 3.9%, or a number needed to treat of 26. And importantly, there was no significant difference in death or hospitalization with aspirin versus placebo. When we look at all four groups, again, a little bit challenging just because the study was not powered to compare individual primary outcomes, but the highest risk of bleeding, at least nominally, or not bleeding, of death or hospitalization, at least nominally, was in the traditional triple therapy arm, and the lowest, at least nominally or numerically, was the apixaban and placebo group. And so then we started to look a little more carefully at the types of hospitalization. And so when we look at the death or hospitalization analysis, really that difference in apixaban versus VKA was driven primarily by the reduction in hospitalization. And so what we did was we looked at cause of hospitalization and whether there were differences among the treatment strategies. And so when we look at hospitalizations by cause, the majority of hospitalizations were due to cardiovascular issues, with other being second, and then bleeding-related hospitalizations being the fewest. When we look at the comparison between VKA and apixaban, there were fewer hospitalizations with apixaban, both all cause, so not only all cause, but cardiovascular and bleeding related. When we look at the aspirin versus placebo comparison, the risk of hospitalization was similar between the two groups for all cause and similar for cardiovascular, but there was a twofold increased bleeding risk with aspirin compared with aspirin placebo. And then again, when we look at all four groups, the lowest risk generally tended to be in patients that were treated with apixaban and aspirin placebo. Now, when we look at ischemic outcomes, which is really the second half or the other side of the coin, when we compare apixaban versus VKA, ischemic outcomes were generally similar across the board, except for stroke, where there was a significant reduction in apixaban-treated patients compared with VKA-treated patients. And then hospitalization, as I mentioned, where there was a 17% decrease in hospitalization with apixaban compared with VKA. Now, the comparison with aspirin and placebo is particularly interesting. Now, again, at least technically, none of the differences are statistically significant. And again, really, it's important to remember that AUGUSTUS was not powered to identify differences in ischemic outcomes. But one in particular that's interesting is the risk of definite or probable stent thrombosis. And here it seemed like there was a numerically lower rate of stent thrombosis in patients that were treated with aspirin compared with patients that were treated with placebo. Now, when you look at the baseline characteristics for these patients, there really are no significant differences. And the overall incidence of definite or probable stent thrombosis remains very low. Importantly, most of the actual events, 80% in fact, really occurred in the first 30 days since randomization. When we look at treatment strategy with apixaban or VKA, again, nominally lower in apixaban-treated patients compared with VKA, but very difficult to really identify statistically significant differences just because the number of events is so small. We're talking about 30 events out of 4,600 patients. And again, similar with aspirin versus aspirin placebo, although at least nominally there appear to be fewer episodes of stent thrombosis among patients treated with aspirin compared with patients treated with placebo. And when you look at all four groups, again, a little challenging to tell just because the numbers were so small, but the lowest rate was in patients that were treated with apixaban and aspirin, at least in those first 30 days. Now, the challenge, at least when we're comparing bleeding events versus stent thrombosis events, is that bleeding events are so much more common than stent thrombosis events in AUGUSTUS. And so for this particular sub-study, we found that definite or probable stent thrombosis is in general very rare and occurs more frequently early after PCI, particularly within the first 30 days. Our data overall support the use of apixaban and P2Y12 inhibitor without aspirin during the first 6 months, given the almost twofold increase in bleeding with aspirin risk. However, in a subset of patients that are at particularly high risk of stent thrombosis and have an acceptable risk of bleeding, it may be reasonable to consider using aspirin for the first 30 days after PCI. And so now we started to think about trying to decipher a little bit more specifically how long to continue aspirin after acute coronary syndrome PCI in these patients. And so, as I mentioned before, even though there was no statistically significant difference in patients in ischemic events with aspirin versus placebo, there were numerically more ischemic events in patients assigned to placebo than aspirin. And here we're talking more specifically of not only stent thrombosis, but then also recurrent MI, as well as urgent revascularization. And as I previously mentioned, the analysis of the stroke thrombosis events in particular suggested that most of these events occurred within the first 30 days of randomization. And what this really speaks to is that long-term, we really want to think about the trade-off between bleeding and ischemic events. It's very difficult. There's really no such thing as a free lunch when we're talking about adding antithrombotic therapies. And so one important consideration is that there is a temporal component to balancing bleeding and ischemic risk. Recurrent ischemic events, specifically stent thrombosis, tend to occur early after PCI or acute coronary syndrome requiring PCI, whereas bleeding risk tends to be more cumulative and would be higher with long-term potent antithrombotic therapy. And so the objective of this sub-study was to explore the balance of risk or bleeding and benefit or ischemic events between randomization and 30 days, and then between 30 days and 6 months among patients enrolled in AUGUSTUS. And so what we did was we subcharacterized each of the bleeding and the ischemic events into a severe category. So for bleeding, that would include fatal, intracranial, or ISTS major bleeding events. An intermediate category, which included all of the events in severe, but then also included hospitalization for bleeding. And then a broader definition, which included everything in intermediate, but then also clinically relevant non-major bleeding as well. And then a similar characterization for ischemic events. When we look at bleeding and ischemic outcomes for aspirin versus placebo, and again, this is now from the point of randomization to 30 days. In patients that were treated with aspirin, the risk of bleeding outcomes, the risk of bleeding tends to be higher than in patients treated with placebo. When we look at ischemic outcomes on the right side of this slide, when we use the broad and the intermediate definition, they tend to be similar. And for severe, there tends to be a lower risk of severe ischemic outcomes with aspirin compared with placebo. And the numbers here, importantly, are absolute risk differences for aspirin versus placebo. When we look at 30 days to 6 months, again, for the bleeding outcomes, the risk of bleeding tends to be higher in patients treated with aspirin. However, when we look at the ischemic outcomes, really the ischemic outcomes now are very similar across the board, regardless of the severity definition used. And so when we look at this on a time to event curves, and this is the severe category from randomization to 30 days, On the left side of the screen, we see fatal intracranial hemorrhage or major bleeding, and this clearly demonstrates the increased risk with aspirin compared with placebo. However, there is a balanced reduction in CV death, stroke, MI, or stent thrombosis in aspirin-treated patients compared with placebo-treated patients. Compare this to severe bleeding and ischemic outcomes from the time point of 30 days to 6 months. And so here you still see an increased risk of bleeding with aspirin compared with placebo. But now that ischemic benefit is essentially a wash. And so among these patients, the use of aspirin early and for up to 30 days results in a roughly equal increase in severe bleeding and reduction in severe ischemic events. Whereas after 30 days, aspirin continues to increase bleeding without significantly reducing ischemic events. And so this again really gets to the fact that for most patients, really an apixaban-based strategy on background P2Y12 inhibitor is probably the most appropriate strategy. But there are certain patients, especially when there's a risk mismatch between bleeding and ischemic events, so patients that are at particularly high risk of ischemic events, where it may be reasonable to continue aspirin for 30 days after the initial, after the index event, and then transition to just a dual pathway-based strategy with apixaban and the P2Y12 inhibitor from 30 days to 6 months. Dr. Lopez and our group also performed an updated network meta-analysis that combined the 4 studies that I had previously mentioned with WOST, which was an earlier study and really was the first landmark study that looked at dropping aspirin in these patients. And so this slide demonstrates the network of the 4 antithrombotic treatment regimens, with the nodes being the particular treatment strategies. And when we look at the forest plots, in general, when we look at all of the major bleeding events as defined by TIMI major bleeding or the trial-defined primary bleeding outcome or intracranial hemorrhage, really the dominant strategy appears to be the NOAC plus P2Y12 inhibitor when compared to the reference strategy of traditional triple therapy. And when we combine all of these patients, it gets to around 12,000 patients. And so really the take-home message for this network meta-analysis is that a regimen of NOAC plus P2Y12 inhibitor was associated with fewer bleeding complications, including intracranial bleeding, without a significant difference in ischemic events when compared to the traditional therapy regimen of vitamin K antagonist plus dual antiplatelet therapy. And so, where are we now? And so in general, in patients that have AFib and recent acute coronary syndrome or PCI, the use of a NOAC at the appropriate dose for stroke prevention, plus a P2Y12 inhibitor without aspirin, really should be the preferred treatment option. And regimens that include a vitamin K antagonist plus a P2Y12 inhibitor plus aspirin or traditional triple antithrombotic therapy in general should be avoided for most patients. If the risk of stent thrombosis or other ischemic events tends to be high, it may be reasonable to consider aspirin use for the first 30 days following the index event or the index procedure. The studies are all broadly consistent with the use of the novel agents without aspirin. And so future guidelines will incorporate a level of evidence A, which is the highest level of evidence for these considerations. And then importantly, the duration of combination therapy for these patients with AFib is key. And in general, after 12 months, oral anticoagulation really should be the default. And really what all of this gets to is really finding the antithrombotic sweet spot that balances the risk of ischemic events versus the risk of bleeding events. And really, so what we're looking for is the right combination of antithrombotic agents at the right dose and for the right duration to reduce ischemic events as much as possible while also minimizing the risk of bleeding. Now, importantly, there are still a number of ongoing analyses with respect to Augustus that will shed even more light with respect to the optimal strategy for these patients. So next on the docket at ESC, we'll be presenting an analysis by the type of P2Y12 inhibitor. Now, most of these studies and most of these patients were treated with clopidogrel compared with prasugrel or ticagrelor. And so this particular analysis will look at outcomes based on the type of P2Y12 inhibitor that was used. We'll also look at outcomes stratified both by Hasblood score as well as by CHA2DS2-VASc score. From the primary analysis, the results were consistent across subgroups with respect to Hasblood or CHA2DS2-VASc, but we'll also be presenting additional data looking at this a little bit more carefully. At the AHA conference in November, we'll be looking at any particular differences in patients that were either naive to oral anticoagulation prior to enrolling in the study versus patients that had prior experience. And then future studies that are in the pipeline, including an analysis with respect to age, an analysis with respect to the time in therapeutic range, and then also in patients that have heart failure who represent a particular higher risk category. And so again, I'd like to thank you all. Thank you, Jonathan, for having me for this webinar. This is a particularly exciting time for this particular field, and I'm excited to answer any questions you might have. Thank you very much.
I hope everyone enjoyed that as much as I did. Amit, great job. Not surprised at all. I had the pleasure of doing a podcast with Amit recently, and you're so easy to talk to, and you make what to me as a simple surgeon is a very complex subject. You make it very, very comprehensible. So I have a question for you. In patients with atrial fibrillation and status post percutaneous coronary intervention, how long would you recommend to give apixaban and clopidogrel for?
Yeah, so that's a great question, and I think that the strategy of apixaban and clopidogrel is probably the most reasonable one. Now, Augustus really only looked at events from 6 months after the time of randomization, and so, formally we can say that that the first 6 months, should be apixaban and clopidogrel. Personally, after that, I think that it really kind of depends on what to do in months 6 through 12. I think most people are in agreement that for most patients after 12 months, it really should just be oral anticoagulation alone without antiplatelet therapy. Between months 6 through 12, in general, if it's a patient that is able to tolerate that regimen, I think, and is not a particularly high risk of bleeding, I think that it'd be reasonable to continue the apixaban and clopidogrel. Alternatively, in the higher bleeding risk patient, perhaps apixaban alone after that would be a reasonable strategy.
Okay, and sort of a not from the same. Actually, yes, it is from the same same participant. Any increased bleeding during the short time that there was triple therapy of ASA, clopidogrel, and apixaban, and how long was that?
Yeah, so I think that's a great question, and I think it really gets to the temporal nature of both the bleeding and the ischemic risk. And I think it's really important that we look at both simultaneously, because in some ways they really are two sides of the same coin. Now, the reality is that in patients with triple therapy, their risk of bleeding tends to be high throughout when we look at from the point of randomization all the way out to 6 months. The question is really what we get in terms of ischemic benefit when we're paying that price for the increased bleeding risk in patients that are treated with aspirin. And so, when we looked at this in the study, the benefit of, so the risk of bleeding was high throughout. There was a benefit with respect to ischemic risk, so fewer episodes of stent thrombosis, especially in those first 30 days. But from 30 days to 6 months, there was still increased bleeding with really no concomitant decrease in the risk of ischemic events. And so I think that's why for certain patients, especially ones that are at particularly high ischemic risk, or patients for whom you really are concerned that the risk of stent thrombosis would either be high or would be potentially catastrophic in the setting of, say, a left main stent or something like that, as long as the bleeding risk is tolerable, it may be reasonable to continue aspirin for those first 30 days and then transition to a strategy of P2Y12 inhibitor and apixaban 30 days out.
I'm just reflecting, on how things have changed since I graduated from medical school, and chatting with a colleague about the wide range of drugs that we now have available to us. It's marvelous. So someone has actually asked a question specifically about recommended regimen for these patients and dosing, optimal dosing.
Sure. So I think the dosing is a very key point, and in some ways it is somewhat subtle and really does identify some of the subtleties between the studies. And so in apixaban, or in AUGUSTUS, what we decided to do, and so early on, when we were designing the study, we had to make a decision with respect to what dose of apixaban to consider for these patients. As you know, in both Pioneer as well as Redual, a lower dose was used. So Redual actually used the 150 milligrams twice daily, which is the approved dose for stroke reduction, but then they also trialed a lower dose of 110 milligrams twice daily. In Pioneer, both of the rivaroxaban-based strategies were at doses lower than what was previously shown to decrease the risk of stroke in Rocket, which was a dose of 20 milligrams daily for most patients. And so, I think intuitively for a lot of people, it does sort of make sense that, if you're adding on these other therapies like aspirin or P2Y12 inhibitor, that, maybe we should just decrease the dose of the oral anticoagulant. The challenge with that is that it's not really clear what you're giving up in terms of stroke risk or in terms of risk of other ischemic events, especially because these lower doses have not been previously studied to reduce risk of stroke. And so because of that, we made a very specific decision early on when we were designing the protocol for the study to choose the dose of apixaban that has been approved for stroke reduction. And this is the dose that was delineated both in Averroes as well as Aristotle, which was the pivotal study. And that dose is 5 milligrams twice daily for most patients. Now, there are certain subgroups of patients. So if the age is greater than 80 years, weight less than 60 kilos, or a creatinine greater than 1.5 milligrams per deciliter, if you meet two of those three characteristics, then the dose of apixaban is 2.5 milligrams twice daily. And again, these are the labeled doses for apixaban. With those doses, we did find in the study that the risk of stroke is roughly half when compared with VKA. And it's not really clear whether we would have achieved that same reduction in stroke had we elected to, put all patients on a dose of, say, 2.5 milligrams or something like that.
Excellent. I have to again commend you. Your means of both presenting and answering questions is so clear and cogent. It's very refreshing. So there's another interesting question here. Or actually a comment first of all. It says in a renal patient can be 5 milligrams once daily. And I think you were suggesting it should be 2.5. I think you said 2 criteria: age over 80, weight 60 kg, and impaired creatinine clearance.
That's right.
Yeah.
And for this one, importantly, so the other important thing, and I think you bring up a great point here, is that the labeled, sort of the labeling for the different non-vitamin K based oral anticoagulants is different by different agents. And so for apixaban, the decision was made early on, and this was well before Augustus, when we looked at sort of the pharmacodynamics and the pharmacokinetics of the drug, exactly how to adjust the dosing in patients with renal dysfunction. And so for apixaban, it's very clear. You don't have to calculate estimated glomerular filtration rate. You don't have to measure creatinine clearance. You don't have to worry about MDRD or Cockcroft-Gault, any of these other sort of equations to get to the bottom of this. It really is just the creatinine. So the creatinine cutoff is 1.5 milligrams per deciliter. And so in patients that have a creatinine greater of 1.5 or greater and meet one of the other criteria, then the dose is 2.5 milligrams twice daily. Otherwise, it's the traditional traditional 5 milligrams twice daily. Importantly, once daily dosing is not really recommended for apixaban. The pharmacokinetics of the drug really don't support once daily dosing compared with, say, rivaroxaban, where the dose is 20 milligrams for most patients. And then, and again, it's 20 milligrams for stroke reduction. In Pioneer, the doses that were studied were different. In one arm, it's 15 milligrams. In another arm, it was twice daily dosing, similar to Compass.
Okay. So an interesting one here. An atrial fibrillation patient undergoes percutaneous coronary intervention. You keep them on Plavix and apixaban for 6 months. Now they need surgery. To keep them on aspirin alone in the perioperative period? Well, what do you do? How would you manage that?
Yeah, so I think that this is a great question. And I think for this, as with most things, unfortunately, really the devil is in the details. And for anyone that does cardiovascular risk assessment and has to formally provide these guidelines or these recommendations in a clinical setting, they sort of know there are really a number of different inputs that factor in when deciding which agents and how long to hold them prior to surgery. Obviously, the first question is whether or not the surgery is elective or non-elective. Obviously, if it's a non-elective surgery, if it's an urgent or emergent surgery, then you just move forward and then sort of deal with whatever consequences on the back end. I would say that for an elective procedure, those first 6 months really are key. And especially in patients that have implanted the newest generation drug-eluting stents, thankfully, the risk of stent thrombosis or a severe recurrent ischemic event 6 months out in a high bleeding risk patient is relatively low. And so there are trials that are ongoing and recent trials that have just been completed, Onyx 1 among them, that have really looked at kind of shorter term dual antiplatelet therapy for high bleeding risk patients. Zion's 28 is another study that should be presented shortly. And so for these patients, I think that it would be reasonable to compress their regimen after 6 months. And so what the questioner suggested, I think, is very reasonable. Whenever I take folks, and again, this is just me in my clinical practice, whenever I recommend that these patients be taken off of their therapy, or if they're being taken off of clopidogrel, at the very least, I recommend that they be on aspirin throughout the perioperative period. There have been multiple studies historically, even in patients that don't have active coronary disease, that may have had chronic coronary disease or at higher risk of cardiovascular events, of the role and the benefit of aspirin in these patients throughout the perioperative procedure, throughout the perioperative setting. And then after that, it really kind of depends where they are in the time course. In some folks, it may be reasonable to restart their dual pathway therapy as soon as is reasonable. In other patients, if their risk is low, from an ischemic perspective, it may be reasonable to just continue on with apixaban or one of the novel agents.
So a sort of procedural question now, Amit. Can you talk about the thought process behind the 2x2 factorial design? How's that unique compared with the traditional parallel design of other studies?
Yep, absolutely. And so with AUGUSTUS, again, early on when we were designing the study, the question really was to design it in sort of a very traditional parallel arm design, or whether to think about doing this 2x2 factorial study. And the factorial design really has a couple of very important implications. So when we compare it to, say, Pioneer or Redual, which are traditional parallel study arm design, in both of those studies, the investigators found that the NOAC-based strategies, so either with rivaroxaban or dabigatran, were superior to a traditional VKA-based strategy at all of the study doses. Now, the key question, and what was difficult for them to disentangle, just because the study design didn't permit it, was, so you had this reduction in bleeding. Was that reduction in bleeding due to the fact that they used the novel agent, that they used rivaroxaban or dabigatran, or was it in fact due to the fact that they actually just dropped aspirin? And so the benefit really wasn't on the anticoagulant side. The benefit really was just on the fact that aspirin was discontinued. And that is, unfortunately, it's a challenging study. It's a challenging question to answer based on those studies. And I'm not denigrating those studies really on any, by any stretch of the imagination. Both were phenomenal, well done studies that really served as a landmark, and both of them came out before AUGUSTUS. What AUGUSTUS really offered was the ability to disentangle this risk of where the bleeding risk was coming from, and to evaluate the independent effects of both the novel agents of apixaban, as well as the independent effect of aspirin with respect to the bleeding. And what this, and because the two randomizations were independent, we were able to definitively answer this question. And so when you look at the risk of bleeding with apixaban is 30% lower compared with vitamin K antagonists, compared with warfarin. But the risk of bleeding is twofold higher in patients that were treated with aspirin compared with aspirin placebo.
Interesting. So for acute coronary syndrome, the role of percutaneous intervention is well documented. Can you discuss how these findings affect your decision to perform an elective procedure in a stable angina patient, or angina, seeing as I'm talking to an American colleague?
Yep. So that's a great question, and I think that when we think about exactly how we're going to manage these patients, obviously, if somebody is having an acute coronary syndrome, or if they're coming in with a STEMI or a high risk NSTEMI and have an angiographically significant lesion, really, there's no question that PCI is the appropriate treatment strategy for these patients. For other patients, and specifically for the patients with stable angina, the question, I think, becomes a little bit more subtle, and the decision making is a little bit more nuanced. Now, over the last 10 years, there have been increasing data really playing to the role of PCI in the stable angina patients. And so when we're thinking about long-term bleeding and ischemic risk for these patients, which agents to put them on after the PCI, I think really question number one is whether or not that PCI absolutely needs to be done, or whether it would be reasonable to manage that patient with medical therapy, right? And so in my practice, I guess the way that I think about it and the way that I counsel patients when I'm in clinic is to really get a sense of how severe their symptoms are, and to get a sense of how maximal their medical therapy is. If they're patients that can be managed safely with medical therapy and can get appropriate symptom control, then I think that it would be reasonable to at least defer PCI for the time being. I think the other important point from not only Augustus, but from the other studies as well, is the fact that for these patients are overall pretty high risk, right? Their risk of bleeding events at 6 months is not low, regardless of the strategy that's used. You know, even in the best possible strategy, the risk of ISTH major clinically relevant non-major bleeding is not low. And so the question is whether or not to even put them on that pathway to begin with. And so in these patients, I think the bottom line is I try to be as aggressive as possible with medical therapy. If we can get by without using, moving forward with PCI, then I think that would be a reasonable strategy. But in those patients that really have, CCS, a grade class 3 or 4 angina, despite being on multiple anti-anginal medications and PCI is warranted, then I think that this study, in addition to Pioneer, Redual, and Trust, really do provide, I think, important and meaningful guidance on the appropriate antithrombotic strategy following that PCI.
So briefly, what inhibitor in these patients?
Yeah, so again, our study looked at apixaban, right? And so for for my patients, I generally tend to use apixaban and clopidogrel. I think the other agents are fine as well. The other studies were well done. There are some patients that may need single dosing just for enhanced compliance or something like that. And the rivaroxaban-based strategies, I think, are very reasonable as well, as are the dabigatran or the edoxaban-based strategies. But the reality is, I think that, overall, I think any agent is fine. The safety profile and the data behind apixaban, I think are very strong.
Well, as we're approaching the end of this, we've got a couple more minutes. There's no other open questions. So I just want to ask you, what's next for you? Do you have any closing thoughts on this study, its deployment, and in general, the care of these patients? especially at this time. You know, we've some unprecedented times. That term is horrible. Unprecedented. These are precedented. But the treatment of coronary artery disease at the present moment, you and I have talked about this. Closing thoughts.
Yeah, so I think that it has been and continues to be a particularly exciting time in this therapy, in this field. You know, I just sort of reflect on what things were like 5 years ago, you know, and so I started, my involvement with the study started in 2014, 2015. And at that time, you know, we really had very sparse data on exactly how to proceed in these patients. Really, the only study was WOST, which was groundbreaking in that, despite being a small study, showed significant benefit in dropping aspirin in these patients. Now, this was something that would have been unthought of in the past, right? Like, are you really going to withhold aspirin in a patient that has coronary disease? And it was a 500 patient study at 2 centers, and really kind of laid the groundwork for the next set of studies. And so here we are in 2020, you know, less than 6 years later, and we have 4 very well designed, large, randomized studies that have demonstrated the role of the appropriate strategy for these patients, which is non-vitamin K based oral anticoagulant, in addition with a P2Y12 inhibitor, which for most patients is probably clopidogrel. We've now treated, or we've studied, more than 12,000 patients across the studies, 4,600 patients in AUGUSTUS alone. And I think we really have a much better sense of what the strategy is for most patients. Now, there is still a fair bit of work to be done, and you did see the sub-analyses that are on the docket for ESC later this month, for AHA later this year, and then we'll continue on with the sub-analyses throughout 2021 and beyond to really kind of hammer down and start to explore some of these more nuanced points. So it's a very exciting time. I'm particularly excited to be in this field. I am, you know, as you know, it really goes without saying, but there are tremendous people that are working in this field. None of this would have been possible without sort of some of my colleagues, Renato Lopez, John Alexander, Chris Granger, Roxana Moran, you know, our fantastic DSMB, our partners at Bristol Myers and Pfizer. As I said, I'm very excited for what we've accomplished and what we expect to accomplish in the future.
Well, a couple of points. Number one, I want to thank Dr. Amit Vora for being not only a clear and cogent presenter, and as I said earlier, for a simple surgeon to be able to understand this stuff, you're doing a great job. And I'm also always impressed by people who show humility in the presence of great wisdom. I could imagine your Oscar acceptance speech, Amit. That was lovely. So I do want to thank you, and I certainly want to thank everyone at the back end at EMG for the technicalities, Michaela and Mary for their help, and of course, most importantly, the audience for listening in. So look after yourselves, everyone. Keep well, keep safe, and see you soon. Bye for now.
Thank you very much, Jonathan.